cataracts. And our first presenter today is Dr. Bart Clarke. He comes to us from the Mayo Clinic in Minnesota, and we're so grateful, really, that he's speaking about fractures and cataracts today. We had asked if one of them would speak about it, and he raised his hand and said he would, and I know a lot of us will really be paying attention and listening. So thank you, Dr. Clarke. You go right ahead.
All right, I'll share my screen here first and pick our slides here. All right, I hope you can see these, and I'll expand this here so we get the full slide up. All right, well, when the request came in for topics, I was thinking back over what I had been doing here in the last year or so. And so you remember last year that we had presented some of our data on basal ganglia calcification. We had done a study here looking at our internal database over 20 years to see what happened, and found some interesting findings that didn't necessarily agree with other studies, but this is why we do the research, because sometimes different conclusions or different findings are available. So I thought for today, what I would do is share what we've discovered in that same database, looking at fractures and cataracts, because these are perhaps less convincingly demonstrated so far. Some of the studies show various findings that are not matched by other studies. And there's still a lot of controversy, especially about fractures. Cataracts, because they've been recognized for longer and studied for longer, I think there's more consensus. But I'll show you what we found when we looked at our database. So here's faculty disclosures. I'm involved in clinical trials for different sponsors, obviously, and consulting with other companies that are hoping to develop new products for treating hypoparathyroidism. Just a comment on this, and when we started this all back in about 2007 or 8, I can remember the day I got the email from, it turned out it was NPS Pharmaceuticals back then, asking if there was interest in this topic and whether it'd be interested in developing a new product that would be used to treat this. And of course, I sent an email back saying, yes, we've got patients with this, we could participate. And then about 9 months later, I heard back again that they were getting ready to do something. So that was the start of all of the investigation, clinical trial investigation into how to treat patients. But you can see NPS Pharmaceuticals has been bought out by Shire Takeda. Of course, in the meantime, Shire Takeda has announced just recently that they plan to discontinue the manufacture of recombinant human PTH1 to 84, Natpara in the US, Natpar in Europe, simply because of manufacturing issues. And they tried to work with the FDA on this, couldn't come up with a feasible plan. And so they said they're just going to have to stop producing this by the end of 2024. In the meantime, Ascendis Pharmaceuticals has come along from Denmark. They've got a new product, Transcon PTH, that looks very promising. Chugai Pharmaceuticals had a product that they were developing that was a PTH1 receptor small molecule agonist that stimulates the receptor just like PTH would, but it's not PTH, it's a different molecule. So what a great concept. And theoretically, this kind of concept might lead to future development of multiple products that could be used in a tablet form or an oral preparation anyway, and affect the PTH receptor. The other companies on the list here are either developing products that are long-acting versions of PTH, and TerraBio has a oral teriparatide preparation they're developing. Extend Bio has a weekly acting, long-acting PTH, and Calcilytics, of course, has molecules that might interact through the calcium sensing receptor to modulate parathyroid hormone secretion. So the last 25 years of biology have led to multiple products and new changes and concepts for therapy. And eventually, hopefully within 5 to 10 years, we're going to have multiple products that could be used for an individual, because the individual's needs are slightly different than other patients with hypopara. So we'll say more about that in the future as these things develop. So today, what I thought I would do is try to talk a little bit about the occurrence and characteristics of low trauma fractures in patients that we have followed with hypoparathyroidism for the last 20 years or so. Take a look at the cataracts in these patients and see what's happened to them. And then just sort of at the end of this, wrap this up and say, okay, how do we manage the condition differently because of the knowledge that we have regarding the broken bones and the cataracts that these patients all can develop. So You'll remember this slide, I'm sure, from previous presentations over the last number of years. Michela Rubin at Columbia did very elegant studies looking at the microarchitecture in bone using different scanning techniques. And one of the papers she published back in 2010 now showed what the bone from patients with hypoparathyroidism looks like compared to controls. The controls are healthy age-matched controls. So as an endocrinologist, when I see a slide like this, usually in a drug company ad, what I would expect is the control patient on the right actually has osteoporosis, but the one on the left treated with a drug doesn't. And yet in this case, it turns out the one on the left is a patient with hypoparathyroidism compared to a normal, healthy age-matched control. And so you can see that the bone certainly looks denser. It's more plate-like than rod-like. It's got other characteristics to it that you might think, well, a bone on the left ought to be very strong bone and very unlikely to break because it's so strong. Turns out there's more to the story than that. And of course, there's still controversy about patients with hypoparathyroidism. Do they have increased fracture risk? Are they better protected against bone loss over time? We generally know that bone density is higher for sure in patients with hypoparathyroidism, and the longer they've had it, the more dense and strong that bone is. But there's still questions regarding the mechanical properties of the bone and how bone under certain stresses responds differently from, say, healthy controls. So bone turnover markers and bone density are shown here in this slide from a number of studies. Drs. Ebeling from Australia, Minnesota from Italy, and Michela Rubin from Columbia, again, looking at some of their data. And what you notice is the bone density first on the right shows that the lumbar spine, total hip, femur neck, and distal radius all have Z-scores that are higher than 0. What that means is 0 would be average for patients of the same age, and a positive Z-score means the bone density of that particular patient is higher than average for men or women their age. So you can see that Z-scores increase by somewhere between 1 and 2, it looks like, with a wide range with the error bars showing that there's quite a bit of variation in this. So some patients would have Z-scores less than 0, but many patients have upper normal or mildly increased values. What we'd expect from that is greater strength of bone, because the denser the bone is in general, certainly in patients with osteoporosis, the denser the bone is, the stronger the bone is, and the chance of fracturing is less. On the left is the bone turnover markers. These are blood tests that can be done looking at certain various parameters that can predict, in a sense, the rapidity of either formation or breaking down of the old bone. And so both are important. In general, there's a balance between these. The formation of bone is about the same as the resorption of bone up until menopause, at least in most women. In men, as we all get older, certainly past age 55, we expect the resorption markers to be a little bit higher than the formation markers. And so as we age, it turns out we tend to lose bone density because the resorption process is a bit faster than the formation process, and the formation process doesn't completely fill in the missing bone. So these markers, P1NP is a formation marker. Osteocalcin is generally a formation marker, but also reflects bone resorption. Bone-specific alkaline phosphatase is a formation marker. CTX telopeptide is a resorption marker, as is TRAP on the far right. So you can see that in general, these markers of formation and resorption are all decreased, perhaps by a Z-score of -2, maybe at the worst. And what that means is that patients will have less formation and less resorption going on in the patients with hypoparathyroidism. So this is, sort of a window into the underlying physiology of the bone, and kind of gives you the sense that patients with this condition probably have stronger bone, but the reason they have the stronger bone is because they're not resorbing it as fast, and maybe the formation, even though it's decreased also, it keeps up with the resorption better. So that's the information here. Now, you've seen this slide also from before. I think Michael Manstadt came up with this originally, but other issues that we deal with, of course, in this population, we have cataracts that can be seen. You see on the left, the normal clear lens, the black part in the middle of the iris, the eye that's the blue color, you can see looks black. Whereas if you have a cataract, a dense cataract, especially when we look in the eyes with our ophthalmoscopes or the ophthalmologists look inside with a slit lamp or other ways of doing this, they see the cloudiness in that black part of the eye. So this is where the cataract forms. The lens sits right behind the opening in the iris there that you can see. And of course, that's where we'd see refraction of the light as it goes through the lens. And of course, then it looks cloudy, it's not clear. So this opacity develops, and you might think that cataracts are all the same. Well, it turns out they're not. There's different parts of the lens that can be affected by certain disorders. It turns out we'll come to that in hypoparathyroidism in a little bit. But other conditions also can cause cataracts that cause the cloudiness in the lens to be in a different part of the lens. And if you said, how can you tell this? Is this something you could do at home? Short answer is you can't. Even we can't do this in the eye examination that we do in a typical internal medicine or endocrinology visit, because we don't have a slit lamp that will tell us where in the lens the cataract is. So we know you have a cataract, we just don't know what type it is. Although if you had diabetes, for example, we might suspect it's a diabetic cataract, but other cataracts occur also. There's also age-related cataracts that many people get as they get older. That's a different type of cataract, and we'll talk about that in a little bit more detail here in a bit. Now, the dental issues, you can see on the left, patients with inherited or genetic forms of hypoparathyroidism tend to have dental enamel hypoplasia. This is less common in those with post-surgical, but I think if you have it long enough, it still could occur. But the presentation shown here in the picture is really more for somebody who had hypoparathyroidism from earlier in life, even from birth, perhaps. So short, blunted roots in the premolars is classic. That would be seen on dental x-rays. There might be absence of tooth eruption, so the tooth never came in during childhood especially. And this can affect the initial childhood deciduous teeth, but it can also potentially affect the adult teeth that come in later. And of course, hypoplasia just means the enamel that covers the surface of the tooth and protects the underlying dentin prevents cavities generally and makes the teeth stronger. But if you're missing the enamel hypoplasia, well, or missing the enamel, at least you can get cataracts earlier. So of course, some of these teeth are prone to having caries or cavities. I won't say much more about basal ganglia calcification. We spent the whole talk last year on that, but you can see the spectrum again, and it can be punctate as in on the left or more diffuse and spread around on the right. And these are different patients over time. One thing I'll say about basal ganglia calcifications, we tried very hard to try to see if we had patients who we had serial CT scans that over time we could tell was the rapid progression, slow progression, reversal perhaps of the basal ganglia calcification. And at least with the patients we had, with the clinical material we had, we couldn't find anybody who didn't have basal ganglia calcification before they got it, number one. And number two, it seemed that the basal ganglia calcification developed very early in the process after the diagnosis. This was true in adults with the post-surgical form, but it was also true in younger adults with the genetic or inherited or idiopathic forms. So there's still, I think, a lot we don't know about this, and calcium and phosphate both are important in this, and what exactly is causing the formation of these is still a mystery. So more to come on that too, certainly more room for research. Now, complications, just in general, Lars Reinmark and the group from the Aarhus in Denmark spent a lot of time early on in this investigative process looking at the risk of hospitalization for various complications. This particular slide comes from their work and looking at patients who are hospitalized with complications. This did not cover outpatients, didn't cover clinic visits, didn't cover pharmaceutical dispensations or other things, but it looked at how common were various complications compared to age and sex match controls. And so what you see here is the differences between post-surgical hypoparathyroidism in the middle column and non-surgical hypoparathyroidism on the right. And what you notice in general is no matter what the complication was, basically non-surgical hypoparathyroidism seemed to have more of it and perhaps a more severe form of it. So when we look at, say, for example, renal insufficiency, the hazard ratio of 3.10 means that the post-surgical patients they had 3.1 fold more common renal insufficiency than the age and sex-matched controls. The confidence interval says, okay, when they analyze this statistically, how wide was the variation in the renal insufficiency in the post-surgical patients compared to controls? And you can see it ranged between 1.73 and 5.55. So this is a fairly broad range. Usually the broader the range, the less number of patients that have this, so it's limited by small numbers of patients and the statistics are not quite as tight, but this is the best we have. If you compare that to the non-surgical hypoparathyroidism, 6.01-fold increased. Their risk of renal insufficiency, kidney malfunction was twice that of the post-surgical patients. And they had a broader confidence interval, as you can see to the right on the slide. Kidney stones, basically post-surgical patients, they had enough patients who had kidney stones to say something about that, 4-fold increased. In the non-surgical patients, they didn't have enough patients to really say much. So the dash there means there was no data. And it doesn't mean that non-surgical patients don't get these things, kidney stones. You might think they would because they have it for longer, most of them either from birth or shortly after birth. So they have this their whole life, and it'd be very reasonable that they would get kidney stones. But in the data that Dr. Reinmark had, there wasn't enough data to say much. Heart disease, you can see relatively lower risk, certainly hazard ratio 1.09 or 2.01, different from the renal insufficiency. So the renal insufficiency seems to be more common than ischemic heart disease, coronary artery disease mainly, but you can see there's a low level of incidence here. Now, one thing to mention is that in the post-surgical hypoparathyroid patients, you can see the confidence interval for ischemic heart disease goes from 0.83 to 1.45. The fact that it crosses one lower limit is 0.83, the upper limit's 1.45. This would imply that because it crosses that 1.0 cutoff, that this is not a significant increase. So that's helpful because the fewer patients, the broader the intervals are. Sometimes they cross one and we can't say much. On the other hand, the ischemic heart disease and the non-surgicals, 1.31 to 3.09, that's above one. And so that would be a statistically significant increase. Neuropsychiatric disease, won't say much more about that, but you can see the numbers here. Seizures, 3.82 versus 10.05 in the two different types of hypoparathyroidism. So clearly up there, and perhaps even more significant in the non-surgical patients, that they have a greater risk of seizures than even kidney malfunction or failure. Now, cataracts, which is one of the things we're going to talk about in more detail today, you can see the data here. Cataracts in the post-surgical patients, again, 1.17, but the confidence interval crosses 1, so that would not be a statistically significant finding. On the other hand, in the non-surgical patients, 4.21, and again, confidence interval goes above 1, 2.13 to 8.34. Upper extremity fractures, as you know, there's been controversy because this particular study found in patients with post-surgical hypoparathyroidism, the hazard ratio was less than 1. What that means is there was a reduced risk of fractures in the post-surgical patients. This was unexpected, or perhaps was more expected at the time because we didn't know whether hypopara patients had more fractures or less. In the non-surgical patients, the hazard ratio went up 1.93, quite a bit more than the hazard ratio of 0.69 in the post-surgicals. This meant that the upper extremity fractures were more common in non-surgical patients. Now, why one form of hypoparathyroidism would have reduced risk of fractures and the other finding in the non-surgical patients, there was an increased risk of fractures. This doesn't make sense, at least based on how we understand the disease, because the same pathophysiology is going on affecting the skeleton. And yet, what difference would it make if it was a post-surgical versus a non-surgical? Potential reasons you could think of, but in general, that is the finding. And still a conundrum, I would say, and other studies, including our own study, I'll show you what we found, but there's still a lot of controversy on this. And I think because we don't have huge populations to study with large numbers of fractures, it makes it very difficult to say for sure what's really going on. But it might be benefited, might be increased. We just don't know. The intracranial calcifications I put on here for completion because you see that around half to even 3/4 of patients of different types of hypoparathyroidism are reported to have increased risk. We didn't find in our population as high a risk as what was shown here, but these patients largely had idiopathic hypoparathyroidism. Many of them studies coming from India. There's other factors that affect the risk of intracranial calcification formation. And I think this is an area that's also very hard to find out. Our, average clinical population that we studied and followed for 20 years, basically, we had about a quarter of the patients had intracranial calcification. So there's, again, variation in the studies. Now, I'm going to turn to our data that has been presented actually at the first set of data here with fractures. We presented this at the American Society for Bone and Mineral Research meeting last year. As a virtual poster number 427, so you can see that for the reference. But what we tried to do in our study was to look at the risk of fracture in our patients with hypoparathyroidism. We know it's a rare disorder. It affects mineral metabolism, primarily causing low serum calcium, increased or upper normal serum phosphorus, and then, of course, parathyroid hormone levels are lower than they should be for the level of serum calcium, and sometimes frankly low or absent, other times inappropriately low normal or mid-normal, depending on the patient. So because of this, and because of the knowledge that the bone density is higher, we sought to find out, well, is there an increased risk of fractures or perhaps not, in spite of their normal or mildly increased bone mineral density based on what we've just talked about in previous slides. So we tried to see whether there's increased fracture risk. And of course, this is an important question, because if there is, then we should be thinking about treating patients who have increased fracture risk to try to prevent certainly major fractures like hip fractures, but also all the other fractures, because no fracture is convenient. They're all painful. Some of them have to be surgically repaired. They all give some sort of at least temporary disability. And these are things that it's part of the condition that we should be paying attention to if it's an issue. All right, so this is what we look to find out. So here's our method, and this is very similar to what we showed you last year on the basal ganglia calcification. We followed all patients diagnosed with chronic hypoparathyroidism here through our electronic record system. We can track these patients by billing code diagnosis, and we followed the patients we had between January 1, 2000 and July 9, 2020. So a 20-year window of follow-up. We came up with 1,014 patients that were diagnosed with hypoparathyroidism that was chronic, and we won't spend more time talking about chronic versus other, but this is chronic patients. We chart reviewed all of these patients to verify the diagnosis, to make sure the billing code wasn't wrong. When you do studies like this, many times the billing codes might label the patient as having hypoparathyroidism, but in fact they had hyperparathyroidism. The billing code was wrong. Whoever entered the data made a mistake. So we verified that these patients really had the condition, and that forms the basis of the cohort that we're then going to look at. Now, in these patients, screening by ICD codes, billing codes for fracture, what we found out that there were, of all fractures, 74 patients who had had a fracture. Now, out of 1,014 patients, only 74 patients with fracture says this is a rare event, even in the hypoparathyroid population. That's a rare disease. All right. So again, it makes it harder to study, but this is what we have. We looked at incident fractures, meaning they occurred after the diagnosis of the disorder, and we found 60 patients who had had those. What that means is the other patients, the other 14 patients, got ruled out essentially because their fractures occurred before the diagnosis, and so technically it wouldn't be caused by the hypoparathyroidism. So that was pre-existing fractures, so a small number there. And then we looked at the number of patients who had incident fractures that were 18 and older, because our study was focused specifically on adults. That's what we had IRB permission to do. And so it turned out we ended up with 57 patients with incident fractures that were 18 years or older. Now, because with electronic databases, you can match age and sex match controls very easily. There's search algorithms that you use to do this. And of course, what we came up with, we looked at adults with fractures in Mayo Clinic Rochester database between January 1, 2000 and July 9, 2020, and who did not have hypoparathyroidism, and who came up with 73,371 patients, a lot bigger number than what we had with hypopara patients. And then what we did is we matched from that comparison database, the 57 patients that we had, we matched them, I think 3-to-1 to look at age and sex matched at the first incident fracture. And that gave us a total of 171 patients who did not have hypoparathyroidism but had fracture. Then we looked at patients that matched also, another 171 patients who did not have fractures, but were age and sex matched controlled to see if we could tell a difference between the hypopara patients and those that were normal patients or healthy patients, average patients who had fractures, and then again against patients that were healthy controls without fractures, just to give us some perspective on this. So then we also looked to see about bone density, because certainly many of our patients have bone density. You can see here that of these patients, the 1,014 total, bone density was done by DEXA, Mayo Clinic Rochester. There was 174 patients that we found who had had that done. And then we turned around and looked at the patients who had incident fractures in our population of hypoparathyroidism to see there were 17 of those that we found, and matching them to the adult patients without fractures, and had 157. So this is the basis for the comparisons that we're going to show you here in a minute. When we looked at the cause of the hypoparathyroidism, we showed some of this last year too, but you can see that the vast majority of our patients were post-surgical, and in this case, post-thyroid surgical, to get their hypoparathyroidism. Probably 37 or 8% had that. And then much smaller numbers for parathyroid surgery, other types of neck surgery, head and neck cancers, for example, autoimmune disease, and this would be a variety of other disorders because they have other autoimmune conditions. We assume their thyroid disease is autoimmune as well, and so the neck surgery that resulted from that was presumed to be autoimmune. But we also had a rare number of patients who had DiGeorge syndrome, trisomy 21, genetic conditions. There were others that were familial because they had other family members with hypoparathyroidism, but no known cause. And that cause we would presume is genetic, but not clarified at the point they were studied. And then there's others who didn't have a family history, and there really was no other underlying diagnoses that we could find that would explain it. So these are the idiopathic group, and that's what we have. So table 1 here shows what we found for various demographic and related data in the patients. In the second to the column from the far left is hypoparathyroidism with fractures. That's the cohort of patients who have 57 patients with fractures that had hypoparathyroidism. Then we have in the next column to the right, age and sex matched controls with fractures, and then age and sex matched controls without fractures. And then we look at the statistical significance of the comparisons between the different groups. So the p-value for hypoparathyroidism versus controls without fractures is the next column. And then finally, the last column, p-value with hypoparathyroidism with controls with fractures. So you get a sense of what we're finding. Now, the bolded numbers, and you can look at as you go down through the columns, there's some that are bolded numbers, some are not bolded. The bolded ones are the statistically significant ones. So what we're looking at is in the patients who had incident fractures, it looks like in the hypopara population, 71.9% were female. That means the other 24.1% would be male. I'm sorry, 8.1 would be female or male. And then across the board, you see that the comparisons were well matched, so that we had a similar percentage of females. Didn't matter what the diagnosis was. We all had 71.9% that met that criteria. With ethnicity, you can see that white Caucasian was the most common, but we had a few people who were other, not clarified because there were a variety of other, but also then a number of patients who chose not to disclose. So we couldn't find that, but that's the breakout of the population. So largely a white population, certainly as you might expect in Minnesota. Body mass index, you can see that they were well matched for weight and height, and you can see that the p-values were no different between them, so that this is not going to be a factor that would explain differences in the findings. Current or former smokers, again, not statistically significant by comparison to either group. Alcohol use, on the other hand, was more common comparing our hypopara patients to controls without fractures. And if you actually look at the numbers, alcohol use, 85.5% essentially had some use present in the hypopara population. Smaller percentages, 70% roughly, in the two age and sex matched controls. So a little bit more alcohol use. Alcohol use, of course, if it's more common, might explain greater risk of falling perhaps would increase fracture risk. So that's an important difference. History of alcohol use, no difference between the groups though. If you look at diabetes, no difference between the different groups. Hypertension, it turned out that it was statistically more common actually in the non-hypopara patients to have this. So this could be interpreted as saying, well, if you have hypoparathyroidism, you're less likely to have high blood pressure. On the other hand, we know that these are select populations and that conclusion would not be valid, even though there is a statistical difference between the different groups. Dyslipidemia, we show here, again, statistically significant, less common in the hypopara patients than in the age and sex matched controls with or without fracture. So that's an important difference as well. Age at fracture, you can see that 64.4 was the average age in the hypopara patients with fractures. 65 was the mean age for the age and sex matched controls with fractures. No difference there statistically. And then finally, the duration of hypoparathyroidism at the first incident fracture in our population cohort, it was 11.3 years with a range that went from half a year to 61.0 years. So quite a wide range in there, but on average, it was about 11 years before the first fracture occurred. Now, types of fractures that we found, because of course, fractures are quite variable. They can occur in any bone in the body. The question is, what's the distribution of the fractures that we found? So here we've shown you the total number of incident fractures at the end of the follow-up, and we've ranked them out by upper extremities, which would include the upper arm bone, the humerus, the forearm, the hand, trunk, vertebral, pelvic fractures. These are axial fractures that occur in the backbone and pelvis. And then also lower extremity fractures. We had the femur, the thigh bone, the lower leg, and then ankle and foot. So that's how we broke them out. P-values are shown in the far column on the right, and what you notice is the only p-value that was bolded was the one for humeral fractures, in which case there were 8 patients with hypoparathyroidism. We had one of those fractures, 10% of the total roughly, and the age and sex matched controls had 11 fractures that turned out to be 3.7% of the total. So clearly, upper extremity humeral fractures were more common in the hypoparathyroid patients than the ones who were age and sex match controlled without fractures. So that was, with fractures. That's, the only statistically significant finding that we had. And of course, this says increased risk of upper arm fractures. That's different from what Dr. Reinmark found. He found that in the non-surgical patients. He found just the opposite in the post-surgical patients. So this is our data. Now, we'll come back to this in more detail. So what about bone density and other clinical risk factors in patients who have hypoparathyroidism and then other patients who have, fractures with or without? So here, what you can see, if you look at the p-values again on the right column, you go down through that, and there was no difference between age at diagnosis of hypoparathyroidism. There was no difference between the age at the end of follow-up if the patient was still alive, no difference in gender between the two groups, no difference in BMI. But in terms of what else might explain the associated risk of fractures, the patients who had fractures during the follow-up period that we followed them for 20 years or so, there was a greater history of fractures prior to the diagnosis of hypoparathyroidism in the ones who subsequently had more fractures after they acquired hypoparathyroidism. So you could say, all right, well, if they were fracturing before they got the disease, maybe the occurrence of the disease eventually later would be, whatever it's going to do. Unless it blocked it, you might expect to see still a greater incidence of fractures, and that's what we found. For other things we looked at, smoking history, alcohol use, age at the time of bone density, and then age at fracture, there really was no statistical significance between these groups. So what that would tell us is that hypoparathyroidism, if you fracture after you got the diagnosis, you might have fractured more before you got the diagnosis too, but really there was nothing else that predicted increased risk of fractures in hypoparathyroid patients from the study that we have with small numbers. This shows the bone density differences. And again, you notice that looking down the p-values in the right column, nothing was statistically significant. So what that says was the patients who fractured more commonly with hypoparathyroidism didn't have a detectable difference in their lumbar spine T-scores or Z-scores, femoral neck T-scores or Z-scores, or total hip T-scores or Z-scores, and then either we also had trabecular bone score numbers we could look at. There was no difference that we could tell. Now, what the T-score is, T-scores compare older folks past age 50 to younger folks in the mid-30s to see how strong the bone is in comparison. And this is by what's called International Society for Clinical Densitometry criteria. In younger people under age 50, because we had some of those obviously in the population, we use Z-scores to look at them. And of course, Z-scores compare those people at whatever age they are less than 50 to men or women of the same age. So it's a more direct comparison to their age. But no matter how we broke it out, the older folks or the younger folks, there was no difference. Okay. Trabecular bone score, if you're not familiar with that, that's a proprietary software program that analyzes the lumbar spine from the DEXA image and uses different engineering principles to estimate the risk of strength of the bone in those areas. And so this gives us typically another independent measurement of strength beyond DEXA, using the same DEXA information to say, okay, is this person at greater risk or lesser risk of fracture? And we won't talk more about that right now, but can answer questions later if there are any. All right, so what we looked at then was the distribution of fractures across age. And in the top panel, this is the patients with hypoparathyroidism. Bottom panel is controls. And by color, the type of fracture that was seen at different time points. And what you notice is, of course, there's many different types of fracture category, many different colors. But if you just eyeball the slide here, it's not obvious that there is any sort of condensation of fracture risk in a certain age decade for certain types of fractures. You might think, for example, hip fractures in yellow would be concentrated in the upper end of the population. And, generally that's true, but there was one at age 40 that you could see also. But you can look through that for the other types of fractures, and we didn't find a age-matched distribution that was significant, certainly comparing it to the control population. And the control population, has the same observation. Green in the control population was pretty common. That was foot fractures, metatarsal fractures mostly. It was also common in the hypopara patient, but perhaps not as common. But statistically, like we said earlier, we didn't have a finding that showed a significant difference. Finally, we looked to try to see by fracture type, was there a difference in what we call time-weighted average of the calcium phosphate product at the fracture? So if calcium phosphate product is important for predicting fracture risk, you might think, well, if it's too high or too low, that might be important, and that might predict a certain type of fracture. Turned out in our hands, the only thing we found that was significant, at least, was humeral fractures. And in this case, the time-weighted average of calcium phosphate product was lower. So this shows you graphically without anything on the y-axis for units, but it just shows what the fracture type was. And looking across that, they're all pretty much around 1, so they're not very different, obviously. But it turned out statistical significance was seen in the humeral fracture, which kind of matches what we found in terms of that greater risk of fracture. But why this would be doesn't answer that question. It just says it was more common to have a lower calcium phosphate product in that group. Okay. Now, the last slide for this particular part of the presentation, we did some what we call multiple logistic regression analysis, trying to look at fractures or factors that could predict fracture risk. And what you notice, the unadjusted analysis is just the raw data. The adjusted analysis makes correction for various factors that we think would be important. And what you notice is in the p-values, there was increased risk, statistically significant risk, for both having hypoparathyroidism and then also having diabetes. That's all we found. Smoking history didn't matter. It was not statistically significant. So despite a lot of looking, because mainly we have a relatively small cohort to study, it's not surprising we didn't find a lot, but this is what we did find. And, it adds to the information that we know about fractures from other studies in patients with hypoparathyroidism. So our conclusion for this poster was that hypoparathyroidism is associated with upper extremity fractures, in particular humeral fractures, not forearm fractures or hand fractures, independent of other known risk factors for fracture. So that's kind of the major finding. Humeral fractures seem to be associated with lower calcium phosphate product when compared to other fracture categories. So that was another finding. Bone density and trabecular bone score did not seem to be pathological in patients with hypoparathyroidism. So the bone density wasn't so low, or the trabecular bone score wasn't so low that you would expect fractures to occur. They were more into the general population, closer to the average of what the normal patients would have. And then finally, history of fractures prior to the diagnosis of hypoparathyroidism was significantly associated with bone fragility in the patients with hypoparathyroidism. And this last point kind of emphasizes that people with hypoparathyroidism have other comorbidities, other things that affect fracture risk independent of the hypoparathyroidism. And if you're unlucky enough, in a sense, to have those, you're going to have a higher risk of fracture even after hypoparathyroidism. We still felt the hypoparathyroidism added to this, but it wasn't the only story in the patients who had fracture. So that's the first part. We're going to talk about cataracts in the next few minutes, and this will be a little bit shorter because the data we have is even less impressive, but we'll show you what we have. This was presented as a poster at the 2021 European Congress of Endocrinology, and we'll show you what we have. So as far as background and objectives on this poster, we know that high calcium phosphate products are thought to increase the risk of soft tissue calcification, be it basal ganglia calcification, kidney stones, nephrocalcinosis, other things, in patients with hypoparathyroidism, including cataracts. So the reason for the cataract formation is generally thought to be correlated with calcium phosphate product. And based on a number of different small case series, cataracts seem to develop predominantly in the posterior subcapsular region of the lens. We'll show you that in a minute. But this is a sort of not unique to hypoparathyroidism, but it's a very unique feature of cataracts and hypoparathyroidism. The mechanism of the cataract formation, though, is still not well understood, and we tried to look at the morphological characteristics of the cataracts in our population and see whether we could come up with factors that might explain the pathophysiology. So here's methods again, and similar numbers, but out of the 1,014 patients with hypoparathyroidism in the interval that we've studied, we found cataracts in 96 of them. So again, a relatively small number, a little bit bigger, perhaps twice as common as the patients with fracture, but not a huge number. So again, it's going to be limited to some degree. And then we matched cataracts in patients who had non-traumatic cataracts, because trauma to the eye can lead to cataracts, but all the other conditions, medical conditions, is of greater interest in this case because this is another disorder that might do this. We found 64,000 patients roughly who had cataracts that were found. And then age and sex matched controls, we came up with 288 that matched our cohort of hypoparathyroidism patients in a 1-to-3 ratio. So here's a very useful slide, I think, for all of us that are not ophthalmologists, because even for me, I think about these things at a more superficial level, even in the setting of hypoparathyroidism. But it turns out that the lens in the eye can have cataracts form in different places. You wouldn't think the lens is that big that it would make any difference, but there are certainly in the studies done on this, certain types of disorders that cause cataract formation in certain places. Now, the age-related cataract that most people get to some degree as they get older is in the center of the lens, interestingly, not on the edge, not on the cortical surface. It's just in the middle of the lens, and this is due to long-term overexposure to sunlight and bright light, and that eventually leads to a cataract formation. But there are cataracts that form on the posterior surface on the right side of the slide. This posterior subcapsular cataract that we're talking about is right there, sort of at the same level in the lens, but it's just on the back surface of the lens. Now, why it's unique to that, or why it forms there and not in the front part of the lens, not in the top part or the middle even, if it is calcium phosphate product doing this, there has to be more than just the calcium phosphate product causing it to form in that location. So not clearly understood at this point. There's what's called cortical cataracts down at the bottom of the lens and at the upper part of the lens. These are also fairly common in certain conditions, but not unique, certainly, to hypoparathyroidism. So we're thinking mostly about what's unique about the posterior subcapsular cataracts, and then also because patients with hypoparathyroidism have other conditions that might cause other cataracts to form as well. So we looked at all this to try to see what could we find. So in our patients, we looked at patients who were having hypoparathyroidism in the column sort of in the middle of the slide, controls next to them, And you can see 96 patients with cataracts with hypoparathyroidism. These are non-traumatic again, 64,211 patients who had cataracts that didn't have trauma, that didn't have hypoparathyroidism. And then we could match them age and sex match control. And then you got the p-values on the right again, showing statistical difference if it's there. One thing I should mention is for statistical difference, the doctors obviously know this because we're always looking for p-values less than 0.05. And of course, as long as it's that way, then of course that's going to be a significant finding. If it's above that, it wouldn't be. So you notice the p-values here are all non-significant because they're all above 0.05. So when we looked at the age at diagnosis, 70.4 in the hypopara, 71 in the controls, or 69 with the age and sex match controls. The ones that were post-surgical, this is the age at which they were diagnosed was older, 71 versus 58.2, which is the non-surgicals. And so that makes sense in a sense because surgery is done later in life usually. And of course, the patient would typically be older than the ones who had non-surgical inherited or genetic or idiopathic forms. For women, it turned out it was about 70%, again, for both age and sex match controls as well. And then for ethnicity, again, you can see how many we had of different types, but at the same time, what you'll notice is that most of the patients with hypoparathyroidism were white. We had 2 blacks, we had a smattering of Native Americans, others, and those who didn't disclose, but comparing it to the age and sex match controls, similar numbers. And again, no statistical difference between them. So age and gender didn't seem to make that much of a difference. Now, what about the types of cataracts and the cause for the hypoparathyroidism? Again, the cohort is a different cohort than the fracture cohort, and it's a different cohort than the ones who had basal ganglia. So each time we sort of present the same data to show the differences between them. In those who had incident cataracts that developed after the diagnosis of hypoparathyroidism, you can see that how many there was and the percentage with it, 9.2% versus 11.5% in the post-surgicals versus the non-surgicals. The age at diagnosis was about 50, it turned out, for the diagnosis of hypoparathyroidism. Duration of hypoparathyroidism in this cohort, 17.1 years before the diagnosis of cataract. And of course, longer duration in the post-surgical than the non-surgical, it turned out. So that was perhaps important. And then body mass index, you notice there was a statistical difference between the patients with hypoparathyroidism and those who didn't have. The patients with hypoparathyroidism had slightly higher body mass index than the non-hypopara patients, p-value 0.033. Smokers, we couldn't tell a difference between the 2 groups, and some, of course, had unknown status. Others we knew for sure. Alcohol use, same comment, no statistical difference between the 2 groups. And, half, roughly 60% of the patients had alcohol periodically at least, but a fair number had not reported that or we couldn't find it. For diabetes, again, no difference, almost exactly the same, roughly 29.2%. And then those with hypertension, fairly common, of course, 70 versus 66, but not a statistical difference. So that's the findings there. And then you can see in the insert, the post-surgical etiology, non-surgical etiology. It turned out, again, thyroid surgery is the most common for certainly the first 2 bars. Parathyroid was much less, other neck surgery much less. And then in the non-surgical groups, the number of cases, it turned out autoimmune was the most common, but only a small number, 6 cases there is shown. And then the genetic disorders, familial, idiopathic, or radiation-induced were also relatively uncommon. But this gives you a sense of the kind of underlying etiology for the hypoparathyroidism when it was present. This slide shows characteristics and the kind of surgery the patients went through, because cataracts, if they mature enough or get to a point where they're visually significant, the eye doctors will say, take it out and we can make your vision better. And that most patients would agree with. So here we have the patients who had overall population of hypoparathyroidism in the first column to the left, then it's post-surgical hypoparathyroidism versus non-surgical, and then the controls. All right, so if we look at the type of cataract seen, nuclear sclerosis, which is that center part of the lens that we talked about earlier. For hypoparathyroidism, it turned out around 60% of patients had a nuclear sclerotic type cataract, not a posterior subcapsular cataract, but this is fairly common even in the hypopara population. If you look at the post-surgicals and non-surgicals, well, it's more common in post-surgicals than non-surgicals, but still a fairly high percentage. And if you compare this to the controls, in our population, in the controls that were age and sex matched, it was more common even to have cataract than it was in the hypopara population, which is interesting because that could be interpreted as saying hypoparathyroidism might actually protect you from at least the nuclear sclerotic cataract. Now, for others, we analyze this as a group because the individual numbers for cortical, posterior subcapsular, and combined forms is relatively small. But what you notice is, in this case, the other types of cataracts, 40.4% of the hypopara patients had this, whereas only 17.1% of the controls had this. So it says this kind of cataract is actually more common in hypopara than it is in patients who don't have hypopara. Now, small numbers again, and it's hard to make much out of these small numbers, but only 5 patients in our cohort with hypoparathyroidism had a posterior subcapsular cataract. And again, these are mostly adult patients past age 18. It might be a different distribution in younger adults who have genetic or inherited forms of hypoparathyroidism, but at least in the adult population, it didn't look like it was certainly the most common anyway. Of those going to surgery, turned out 58.3% of our hypopara patients had surgery. In the controls, it was 49%. So, you might argue that maybe that reflects the fact that these cataracts are more visually significant. Patients function less well with them and they'd rather have more surgery. So that's how you could interpret that. But no statistical difference in terms of the values. How they did the surgery, there's different ways you can do it. You can just essentially suck the cataract out of the capsule that holds it in place, and that's oftentimes done, and that's where they put an intraocular lens in place of the cataract that's damaged. They can also what they call phacoemulsify the cataract, which sort of dissolves the cataract, and then they suck it out. But the way we do cataract surgery here, at least in this population, it looked like the phacoemulsification was more commonly used for sure, and it was only a few patients who had the extracapsular, intracapsular cataract extractions. Age at surgery, older, obviously, as you'd expect, 73 for the hypopara patients, 74 for the controls. Posterior capsular opacification after surgery, and this is a complication of cataract extraction where they have to use a laser essentially to damage the opacification that occurs on the backside of the eye, and they can do this very precisely and not burn other things. Only a small percentage, 10.7% versus 9.2% had this, and not much difference between the post-surgicals and non-surgicals for that. And then the interval between surgery, initial surgery, and then the posterior capsular treatment turned out to be about 4.5, and I believe this was years for the hypopara patients versus about 7 years for the for the non-surgical patients. 7 years for the controls. So that's the data that we have for the treatment of these cataracts in our population. If we said, what about the total study population looking at serum calcium and phosphate effects on the types of cataracts? If we looked at tertiles of time-weighted average calcium versus phosphorus in the top panel, table 3, you can see there was some difference between them. For types of cataracts other than nuclear sclerosis, there was a difference, and these were statistically significant differences where calcium and phosphorus were different from the controls. For cataract surgery itself, it turned out there was no significant difference between them. So it made a difference for what kind of cataract the patient developed, but not for the kind of surgery that they had. Table 4, influence of serum calcium on the need for surgery. You might think that the higher the calcium, the higher the phosphorus is, probably the risk and need for surgery would go up. On the other hand, what happened in this group is that for time-weighted average for calcium, less than 8.85 milligram per deciliter or above that, there was an odds ratio of 0.57, which means there's a reduced risk of surgery with this kind of serum calcium ranging. And with phosphate, it turned out there was an odds ratio that went up to 1.64. Again, neither of those p-values, 0.282 and 0.375, are statistically significant. So it didn't seem to make a difference in terms of whether the patient got surgery or not, depending on where their serum calcium and phosphorus levels were across the population. When we do these time-weighted averages, we take all the values ever measured on a given patient from the 20-year window. and then there's a way through the software we can analyze that and give you some sort of estimate of risk. So our conclusion from this is that basically peripheral damage to the lens rather than nuclear cataracts is more typical of hypoparathyroidism, and that it may be correlated with hypocalcemia or hyperphosphatemia. And our extrapolation from that is that if we control these biochemical parameters better, it may reduce the risk of cataracts, similar to what we say about kidney malfunction, kidney stones, and other conditions. So if we think, to kind of wrap this up, how we treat patients with hypoparathyroidism, we now have got guidelines published both by the European Society and the International Conference, the second set of guidelines that have come out. Initial guidelines published back in 2015, and the new ones being published in the Journal of Bone and Mineral Research, already online, but to be published in print, I believe, this month or next. They're also doing new guidelines for hyperparathyroidism as well. So this is kind of a package that should be very helpful for physicians to help take care of this. Aliyah Khan has published the Canadian International Guidelines, and then of course there is what's called an ACE disease state clinical review on postoperative hypoparathyroidism that's been published by endocrinologists that are active and involved in the American Association of Clinical Endocrinologists. That's an older review now, but it's out there. So the treatment targets, based on the data we have and based on these kinds of studies, have said that, well, if we can maintain low normal serum calcium, high normal serum phosphorus, 24-hour urine calcium less than 300 milligrams, 7.5 millimoles in international units, and then a calcium phosphate product still right now quoted as less than 55 milligrams squared per deciliter squared, this should mitigate or minimize or decrease the risk of complications developing across the board, but specifically in terms of cataracts, the basal ganglia calcification, and fractures. So how this is done, Maria Luisa Brandi published this back in JCNM 2016. It hasn't changed much in terms of conventional therapy because we have no better way to do it yet. Calcium, obviously, in some form, citrate or carbonate in varying doses is used. Calcitriol, rapid-acting vitamin D, activated vitamin D, otherwise called, in certain doses anyway, is often given because we can change the calcitriol dose more rapidly than we can change the vitamin D2 or D3 dose. And vitamin D2 or D3 is still recommended in combination with calcitriol because both forms are important. Calcitriol to change things day to day if we have to, because the calcium is too low or too high. Vitamin D2 or D3, many tissues in the body cannot use calcitriol. And if they don't have adequate circulating D2 or D3, part of your tissues in the body would be deficient if your blood level is not in the normal range. Thiazide diuretics, low salt diet can be used when necessary to manage high calcium in the urine that can't be managed or manipulated any better through the calcium, calcitriol, vitamin D2 or D3 pathways. So this is still used in a fair number of patients. The low salt diet, we oftentimes overlook or don't emphasize enough, but thiazides work much better if you have a low salt diet than a high salt diet. And the high salt diet sometimes actually overcomes the beneficial effect of the thiazide. Phosphate binders, low phosphate diet, that's also important to control the hyperphosphatemia. All right, so European Society guidelines that were just published here several months back, here's what they conclude. And, it's kind of all the things that we've said. We try to keep things in the low normal range for calcium, high normal range for phosphate if we can, phosphate product within the reference range. Magnesium is important in this because too much or too little magnesium will actually block the release of parathyroid hormone if there is tissue still capable of releasing parathyroid hormone. And a fair number of patients, at least post-surgical patients, seem to have some residual capacity for that. Urinary calcium, we try to get in the normal range for gender. In general, men have higher 24-hour urine calcium than women. And the new guidelines would say 300 milligrams or less is the target for men, 250 milligrams or less is the target for women. And that's a little bit of a difference from prior guidelines. Adequate vitamin D, and then, of course, focus ultimately on long-term well-being and quality of life as being, key importance, obviously, beyond the biochemical things that we seem to focus on a lot, but the quality of life is even more important. Now, the international guidelines that are being published in the next few months in the Journal of Bone and Mineral Research, this is one of the points that was made in those guidelines, and a fair number of your physicians that are at this conference all participated in helping write these guidelines, at least at some level. So one of the conclusions from this particular summary paper says, how are patients with hypoparathyroidism managed, using a very statistically rigorous way of analyzing the data and saying, what can we really say? What can we conclude that's valid and not just extrapolation from what we think we ought to be doing? So in patients with chronic hypoparathyroidism, the panel suggests conventional therapy is still the first line therapy. And this is actually based on clinical trial data that we have, very weak supporting data essentially, and it's considered to be low quality evidence, at least by randomized controlled trials that are the highest level of evidence. So the comment that was in here and is expanded on in the text of the article says that when conventional therapy is deemed unsatisfactory, either because of biochemistries not being able to be controlled or quality of life not being where you want it, either consideration would be a reasonable justification for using PTH analogs. And so more to come on that. Here's more detail about what they're saying for how to treat calcium and active vitamin D analogs would help this with the goal to keep your serum calcium in the target range, the lower half of the normal reference range or just below that. And at this point, it's not really clear yet how best to balance the need for calcium and calcitriol. And in Europe, of course, they focus more on calcitriol and less on calcium. Here in the US, we tend to focus more on calcium and less on calcitriol. So differences in philosophy of how to treat this and control it. We do usually whatever it takes for the patient to get their best control, but there's some underlying principles there, whereas in Europe, they would start with higher doses of calcitriol. We would usually use lower doses of calcitriol. Trying to get the serum calcium to be controlled and symptoms related to that controlled, but not cause hypercalciuria, high urine calcium, which is virtually impossible to avoid, but can be if careful titration is done, and sometimes with thiazide type diuretics. In general, we're trying to get low plasma calcium levels mainly because the urine calcium is less in that setting. If you raise it up too high for blood calcium, it spills over in the urine and then the urine calcium goes up. And each of us is different how that happens. Some people, it doesn't take very high calcium in the blood to raise the urine calcium. Other people, it takes a lot more. Again, difference between individuals. So patients with hypoparathyroidism, not looking at the rigorous statistical analysis of these upcoming points, what was said is urine calcium less than 250 milligrams for women, less than 300 milligrams for men was the target. And data from the general population has shown a strong correlation between the level of urine calcium and development of kidney stones. In patients with hypoparathyroidism, we don't really have that same data to the same quality. And because of that, it's much harder to say what should the calcium phosphate product be ideally, because even with levels in the mid 30s, with some of the studies that have been done so far, these complications still occur. So it might take a much lower level than what we're currently living by. We try to avoid hyperphosphatemia. We try to normalize plasma magnesium. We try to keep the serum 25-hydroxy D level in the normal range, because that's the form of vitamin D that many tissues in the body use preferentially over the calcitriol form of vitamin D. We can treat hypercalciuria with thiazide diuretics in the low sodium diet, but must carefully monitor blood pressure, magnesium, potassium, and renal function, because thiazides can drop the blood pressure too much. Patients get lightheaded or dizzy. We don't want people falling over and breaking something because of that. So we're careful with that. But if it does work, at least to certain doses, this oftentimes is very helpful, helping keep that urine calcium below the cutoffs that we've just mentioned. Parathyroid therapies are certainly recommended if any one of the following are present: symptomatic hypocalcemia, hyperphosphatemia that we can't control by other means, kidney insufficiency, hypercalciuria, or just poor quality of life. And this covers probably most patients with hypoparathyroidism, especially the poor quality of life, because everybody is so symptomatic much of the time, and there's no way to control it through conventional therapy. Poor compliance, malabsorption, or patients who cannot tolerate large doses of calcium or active vitamin D can benefit from therapy as well. And individuals who have to take high doses of calcium or vitamin D, certainly more than 2 grams of calcium a day or more than 2 micrograms of vitamin D a day, could also benefit from PTH therapy. Now, one of the issues is right now, besides the recombinant human PTH 1 to 84, known as NATPARA, in the US, NatPAR in Europe. We really have no other improved agents for use, but you realize that teriparatide, which is only approved for osteoporosis treatment, sometimes is used at least in twice a day, sometimes 3 times a day injections versus the NatPara single daily injection. PTH in different forms can be given by pump therapy, can be given by implantable microchip. There's other analogs coming. TransCon PTH is the nearest. They're undergoing FDA review here in the next 6 months to try to see if this will get approved. And if so, this will be another option for treatment that we don't currently have yet. The clinical trial data looks very good and very promising, I would say. There are molecules that can bind to the PTH1 receptor. First one that was ever tested was the PC0371. This is the Chugai product that failed in the first cohort of the phase 1 study. The 2 patients out of the 5 patients got liver inflammation, and they said, we're dropping the drug. This is too dangerous. We can't use it. But like I said earlier, there's hundreds of products like this that are being designed through algorithms that can design binding pocket molecules that will fit the pocket and do the things that the molecule should do. So I'm told that there are hundreds of these that can be used potentially. Stem cell therapy still on the horizon, would be a great therapy if we could do it. Much more convenient than most of these other options. And if it's your own cells, of course, you don't need immunosuppression. And then finally, parathyroid gland transplantation, which there are some patients who do very well with this, but typically the glands fail sooner than they want. They require major immunosuppression, about the same as with a kidney transplant. And so this is difficult. But these are all on the horizon, and there are various people, various groups around the world working on these. So I'm going to stop here and just leave you with, again, sort of the big picture. We know this is a rare disorder. 75% of patients or so at least have hypoparathyroidism caused by surgery. We didn't say anything about that, but there's lots of efforts going on to try to minimize the risk of hypoparathyroidism at surgery by various imaging techniques, visualization techniques that are fairly sophisticated that may actually help our surgeons do the job better. The acquired causes, we know these do occur for various other reasons. Most of these are rare conditions. Commonly, autoimmunity is fairly common, but some of these other things, iron and copper overload, radiation, treatment, et cetera, are fairly rare. Magnesium deficiency in excess can occur, and this is always a surprise when we find it because we don't expect it, because it's not that common. And yet magnesium is important. If it's too high or too low, it affects the ability of parathyroid glands to release parathyroid hormone. Genetic causes are of great interest right now and can be increasingly tested for with a single tube of blood, essentially. Many vendors out there will offer this test. And of course, they find things that we didn't expect clinically, but it's very useful to know when those things are present. Finally, the last point, treatment should include calcium and calcitriol supplementation, vitamin D2 and D3, don't forget that. Magnesium as needed, thiazide diuretic as needed, and then finally PTH analog treatment for what we have in the near future. I'll stop here and show you where I work looks like today, actually with the sun out, amazingly. This is kind of maybe a late summer photograph, and on the left, the first building on the left that you come to is the Mayo Clinic building. There's a Gonda building next to that, and then you can see Methodist Hospital straight ahead, and on the right side is the Plummer building and associated buildings. So this is the heart of our campus, but if you ever visit Mayo Clinic, this is what you're going to see. We're on the 18th floor for endocrinology in the Mayo building, and if you come by or are here or need to be seen, feel free to contact us. I'll stop there and hope I'm still within time limit, and I'd be happy to answer questions.
Thank you so much, Dr. Clarke. Oh my goodness.
Okay.
Yes, we do have a few minutes for questions. So one of the questions we have is, if you have calcium-related cataracts, once you've gotten them corrected, will they return unlike regular cataracts because of the calcium buildup?
Right. So what they would do if you had surgery for cataracts and they either pulled the lens out of the pocket it sits in the front part of the eye, what they replace it with is with an artificial lens. This is what they call an intraocular lens implant, essentially. The intraocular lens implant does not calcify to my knowledge. So as long as you've had it done once, or even if they do that phacoemulsification where they sort of dissolve the lens and suck it out in layman's terms, you're not likely to have recurrence of the implanted cataract. Now, there was that thought that maybe on the backside of the cataract or the backside of the lens, you could have further opacification that develops. And this is outside the lens a bit, maybe in the connective tissue behind the lens. So I think it's possible you could have that happen, but if it did, they would laser it and treat that. But it's not going to be the same cataract that you had the first time because the lens is gone, essentially.
Very good. So let's see, do patients on Natpara or Forteo for many years have a normal fracture or lower risk?
Okay, so if you think about this, if you've got high bone density with low bone turnover, it means the bone is not very metabolically active. One of the concepts related to that is if you can't have very metabolically active bone because you don't have PTH to stimulate it, the bone itself has a harder time repairing microcracks and microfractures in the skeleton. So if you accumulate microcracks in the skeleton because you can't repair them fast enough because the turnover isn't high enough, essentially you're at greater risk of fracture. So that's where the concept comes about the bones become more brittle, the age of the calcium, the mineral deposits in the bone gets older, it becomes more dysfunctional, and so theoretically it could lead to an increased risk of fracture. Whereas the other side of this is if you have denser bone, you should have less fractures. Now that's a more simplistic view of this, but that also plays a role. So, honestly, I think, theoretically, at least in different patients, it could be either way. You could have greater risk of fracture just because of the unique properties of the mineral and the bones and all the other components of the bone that you make, where you might have greater risk. On the other hand, if you're lucky, you don't have those things, but you have more dense bone. And even with lower turnover, less ability to repair microcracks, you might still have stronger bone. This, of course, could change over age because as we all get older, certain things don't work as well, et cetera, and it could change over time. Now, to really figure this out would require a much larger study than what we've done or what Lars Reinmark has done. I don't know that there's any database in the world right now that would have enough patients to really look at that in detail, but perhaps the European consortium databases that are being developed, where they'll have thousands of patients of this disorder, might give us more insight on that than what we've been able to obtain through the registry studies or single institutional studies.
Okay. And if you have joint replacement, are there greater risk or would the healing be any different?
Yeah, so that's a very important question also because joint replacements are so common. We think that people who have osteoporosis of the usual type, they get joint replacements. The bone, even though it's weaker than usual, has no trouble hanging on to the joint replacement, and failure of joint replacements is about the same as in the general population. I suspect it's similar in hypoparathyroidism, although I don't know of any study that's looked at that in any detail because theoretically, for all these reasons we just went through, the bone might be stronger and hang on better, or it might be weaker and it might get looser. The implant might get looser and eventually fail and all that. I've not seen any studies. And, my own impression clinically is that for patients I see, it's a rare patient who seems to have needs with joint replacement or replacement of revisions of previous joint replacements because it didn't work. So I suspect it's not much different than the average. So.
Okay. Can you explain the mechanism that leads to so much muscle pain for us?
All right. Well, that's a different question, not covered in this talk, partly because I think the data for that is less available and less well fleshed out. Certainly muscle pain. If you think about muscle pain, what drives muscle pain? Well, it's inflammation. It's the contraction of the muscles leading to cramps. It's other disease that muscle might be affected by. Inflammation, for example, muscle inflammation is a fairly common condition that leads to a lot of muscle pain and dysfunction. So the cause in hypoparathyroidism for the muscle pain, I think, is multifactorial. It's different things in different people. I don't know that there's a unifying explanation in everybody, but we know that whatever the underlying muscle physiology is, that having lower calcium is going to make that muscle more likely to cramp. And so cramping is probably a part of it. If the calcium in the blood is low and there's not enough calcium to get into the muscle to make the muscle relax, which is also important, then that would be another factor that people who have low calcium of any cause would be at risk for. So I wish I could give you a simple answer. In general, I would say, well, given the lack of knowledge in this area, I think it makes great sense to optimize, for sure, calcium, phosphorus, magnesium, because those are big things that affect muscle function also. But because muscle function depends on potassium, sodium, and a few other things, also make sure that those things are optimized. Now, even if you did all that, I'm not sure it'll solve all the muscle pain, but pain comes from these different conditions, and I'm sure the low calcium or fluctuating calcium levels in the blood contributes to this in a big way.
Okay,
Okay,
very
ma'am.
good. And then do you have a recommendation for the best type of magnesium for hypopara patients?
Yeah, I don't think anyone is better than any other, because they all get absorbed to some degree. Of course, some people find one causes less irritation to the intestine or stomach than others. In general, I tend to recommend, at least first, I usually try magnesium oxide because that's widely available in different doses and seems to be something that at least most of the patients I've treated with it, they seem to do pretty well. In a given person, if they tried that and it didn't work or it caused other side effects, well, I'd move on to other forms of magnesium, but those may be harder to find. Not all pharmacies carry them. And the pandemic supply chain issues have not helped us in this regard, because even calcium of the usual type you can't find anymore, or it's not in your area, or it's not been delivered yet. So I suspect the magnesium would be similar.
Okay. And if you're diagnosed with hypopara at a young age, let's say less than 25, will this affect your risk for cataracts or fractures?
Well, so it looks like it would to a small degree. And, if you said, because even out of our 1,014 patients we only had 57 fractures, it was 92 or 97 that had cataracts in the entire next 20 years. Well, the chance of getting a cataract if you got hypopara is still very low. But as you get older, past, I'd say probably page 50 to 60, age-related cataracts are more common. So that happens depending on work and lifetime exposure to sunlight and all that. The hypoparathyroidism that causes or leads to the posterior subcapsular cataract seems to be much less common. And so I think even though that's a classic form of cataract for the patients with this condition, I'm not sure that you have a terribly high risk if you acquire this even in the 20s, because I think if you had this at birth or shortly after birth, it'd be more likely you would get those cataracts later in life. As you're an adult, certainly if it's post-surgical or other, maybe that risk is less. But it's hard to put quantitation to those numbers because we just don't have enough data. So,
Okay. Well, thank you, Dr. Clarke, for so much of your time this morning. We really appreciate you did a great job of really explaining a lot of things for us. So we appreciate that. And